Good morning, everyone. I make that 7:45, so I think we'll make a start. I'm Graham Sills. I'm Senior Lecturer in Pharmacology here at the University of Glasgow. It's a real pleasure to chair this session this morning. We have a small, select group, and well done to you all for your perseverance in making it along for 7:45 on the final morning of the conference. As you know, standard oral presentation approach, so each speaker will have 10 minutes and then we'll have 3 or 4 minutes for questions after each speaker. And without any further ado, I will now introduce the first presentation, which is on fentanyls and nitazenes, agonists at the mu opioid receptor, and the presentation will be given by Norah Alhosan from Bristol. Norah.
Thank you very much. So, introduction. Fentanyls are major contributors to the opioid epidemic in the USA. The graph here shows the number of overdose deaths from 1999 to 2021. As you can see here, there has been a sharp increase in deaths related to fentanyls from 2015 till today. Nitazenes are also illicit synthetics, opioids, and recently there has been emerging deaths involving nitazenes. Both fentanyls and nitazenes are highly potent opioids. For example, here carfentanil is 10,000 times more potent than morphine. Isotretinoin is 500 times more potent than morphine. So in order to rescue an overdose case, the antagonist naloxone is the drug of choice. However, there has been some reports that shows higher or multiple doses of naloxone was required for reversal compared to, for example, heroin overdose case. So we wanted to see if we can see the same thing in vitro. So we wanted to study the ability of naloxone to reverse fentanyls and nitazenes at the mu opioid receptor. To do so we used 8020 cells. They have a neuronal phenotype, and we have stably expressed them with human mu opioid receptor, and we use membrane potential sensitive dye. So I'll go you through how the assay works. So we load the cells with the dye. The dye is membrane permeable, so it will distribute all over the cell. And when we add the agonist, the G protein is activated. Beta-gamma subunit will open the potassium channel. Potassium ions will flow out of the cells, causing hyperpolarization. And because the dye is membrane potential sensitive, and it will follow the potential gradient, so it will flow out of the cells, causing decrease in the fluorescence. So this is like what we see. When we add morphine, we see a drop in signal. That's a measure of this cell being hyperpolarized, and the response is quickly reversed by naloxone. The first thing we wanted to do is to look at the potency. Here at the top, you see the concentration response curves for the fentanyls, and at the bottom, the same for the nitazenes. In both data sets, we included morphine and Damgo as standard control opioid agonists. So what we can see clearly, all agonists were more potent than morphine, and all agonists were full agonists. And here in the table, you see the EC50, and I want to highlight here carfentanil was the most potent among all of them. And carfentanil was 30 times more potent than morphine. Well, this observation has been shown also in other in vitro assays. And the reason why, and I showed you in the first slide that carfentanil is 10,000 times more potent than morphine, but here we see 30. And in other also in vitro case studies, we found less. So the reason why carfentanil is less potent in vitro compared to in vivo is currently, we don't understand that yet. Moving to the exciting bit, so we wanted to look at naloxone. And the way we designed the study, we wanted to replicate an overdose case where we picked the EC75 concentration of the agonist from the curves I showed earlier. So we added the agonist first to replicate like an overdose case, because overdose comes, they have the agonist first, and then we give them naloxone. And then we treated the cell with increasing concentrations of naloxone. As you can see, as we increase the concentration, we see increased reversal. In contrast with carfentanil, we required higher concentrations of naloxone for reversal. It's obvious here if you could look at the green trace. It's 30 nanomolar naloxone completely reversed morphine, while 30 nanomolar barely did anything with carfentanil. You see here the data at the bottom for all the ligands for fentanyls. So what we found that morphine, damgo, fentanyl, and amfentanil were equally sensitive to naloxone. However, sufentanil required more concentrations of naloxone, followed by omifentanil, and the least sensitive was carfentanil. And with the nitazenes here, isotretinoin and etranitazene, we found the same thing, that they required higher concentrations of naloxone for reversal compared to the standard opioid agonist, morphine and damgo. Well, this is not quite what we expected. We know that the agonist, when the agonist leaves the receptor, the antagonist binds. So we know that the antagonist should reverse all ligands equally. So what we did next, but I don't have the data here because of the time, we did shield analysis. So we did the same experiment, but we added naloxone first to reach equilibrium, and then we added the agonist. And we found the same thing, that some fentanyls and nitazenes required higher concentration of naloxone to see reversal. So next we wanted to see if the agonist dissociation time could explain the sensitivity to naloxone. And how we designed the study, as previously, we added the agonist at EC75, and we treated the cells with 10,000 times naloxone KD, so it's 10 micromolar. So the idea being that when the agonist leaves the receptor, there will be an excess of naloxone, so there will be little chance of the agonist rebinding. That will give us like an apparent dissociation time. As you can see here with morphine, naloxone quickly reversed the response. Down here with carfentanil, it took longer to leave the cells in order for the naloxone to do the work. In the table here, so we fitted the curve to exponential fit, and we have the half time. As you can see here, these ligands were rapid to unbind from the receptor, and these are the same ligands that were equally sensitive in the previous slide. At the bottom here, these agonists, including nitazenes, took longer to unbind from the receptor, and these agonists also were less sensitive to naloxone. They required higher concentration of naloxone. So we wanted to see if there is any correlation. So here in the graph, we have the dissociation half-time for all the agonists across their sensitivity to naloxone, and we found really good correlation. So the longer the agonist stays on the receptor, the higher the requirement of concentration of naloxone to see reversal. Next, we looked at the correlation between the agonist lipophilicity and the apparent dissociation half-time. The reason being both fentanyls and nitazenes are highly lipophilic, so we thought that they might be concentrated around the receptor in the lipid membrane, so that will give them higher chance of staying with the receptor for longer. But however, we found very poor correlation. You can see here these agonists have similar lipophilicity, but their half-time is widely variable. At the bottom here, the last thing I want to show you, that we looked at the agonist potency, whether the potency of the agonist could predict their potency to naloxone, because we have been reading in the anecdotal report that, well, these agonists are highly potent, that's why we need higher concentration of naloxone. But we found a poor correlation. These agonists have pretty similar EC50, but their requirement of naloxone differs. So in conclusion, what we found that opioid agonists are not equally sensitive to naloxone in vitro, and that was similar to the reports case series we found in the literature. And the sensitivity to naloxone correlates with the agonist dissociation half-time. And we found poor correlation between the agonist potency and sensitivity to naloxone. And we didn't find a good correlation between the agonist lipophilicity and the agonist dissociation half-time. And thank you very much for coming this early and listening. I hope it was worthwhile. Questions?
Nora, thanks for getting the session off to such a fantastic start. That was a really nice presentation. I would like to open the floor to questions. There are some microphones. Please use them because the session is being recorded. So there's one in that aisle and one over on the other side. So.
Hello.
Good morning, Nora.
Good morning.
Wonderful talk. Thank you.
Thank you.
So there isn't a correlation between the lipophilicity and the association of naloxone. Would some of these agonists possibly be allosteric modulators? Do you think they have another binding site on the mu-opioid receptor?
We're not sure about that. We haven't studied that, but I think that would be interesting. But I don't think, well, I can't comment on that at the moment. But that's a very interesting thing we need to look at. Yeah, thank you very much.
Right, you may not have a very big audience, but they're very interested. I thought it was really fantastic presentation.
Thank you.
And it's also extremely important regarding, obviously, fentanyl.
Yeah.
It fits perfectly with a type of compound we had on 5-HT1A receptors about 20 years ago, whereby we had an antagonist pose, of a spiperone pose, we could model the compound going into right down to the receptor and switching on the dry domain, so it became a hyperagonist. The pharmacology you show exactly the same for mu-opioid compared to this 5-HT1A hyperagonist, which followed, it was a hyperagonist all the way through in vivo, and it would have gone into man apart from a slight change. And the Emax is actually higher than the Emax. It was exactly the same.
Yeah.
Okay, the Emax is actually higher for your fentanyl analogs by the look of it. And it wasn't related to the lipophilicity. So I think this is extremely important for how fentanyl works and the danger of it. So it's a fabulous presentation.
Oh, thank you very
We'll
much.
have a chat about it for...
Yeah, definitely, yeah.
Next question.
Jesus Giraldo from Universidad Autónoma de Barcelona. Beautiful talk.
Thank you.
Congratulations. So you have explained the behavior of different mu-opioid receptor agonists in terms of binding kinetics, no? And the dissociation rate constant. So imagine that you want to design an antagonist for this receptor. You would focus on potency, or you would focus on the binding constants, the association, dissociation. Maybe it's better to have a higher dissociation rate, dissociation constant for the antagonist in order to be there and avoid the rebinding of the agonist. So in terms of binding kinetics, how will be your drug discovery design?
Well, I know that there's another antagonist called naloxone. It has longer half-time, but the problem is with having an antagonist with long half-time that, well, when you rescue an overdose case, we have this withdrawal symptoms, and the victim is not happy, and sometimes they get aggressive, and they may go and have higher dose to get the high. So I think it's difficult to say that we need, well, I don't have, to be honest, the correct answer, but in my view that if we need to strike a balance that, well, we need to rescue the overdose case, but at the same time, you don't want to reverse all the responses of the opioid agonists because the the people will go and then will leave to get a bit more. But yeah, I hope that answers your question.
Yes, thank you very much.
Thank you.
Okay.
Thank
Thank you. Perfectly on time. So well done, Nora. Our next speaker will give a presentation on resilient and vulnerable rats to acute footshock stress, showing different glial cell responses. So paper will be given by Marta Valenza from Sapienza University in Rome. Marta.
Hi. So thank you all for being here so early in the morning to hear about my research. So this is my disclosure statement, because I'm paid by this company right now, but I'm presenting data that are not related to the project that I have with them today. So first, a little bit of background. So we all know that the stress is important for adjusting to change in environmental changes. So it is good. But even a single traumatic event can lead a vulnerable subject to develop psychiatric disorders. And it's not only the nature of stress, but also the characteristic of the subject involved, its genetic background, education, and so on. So the consequences of chronic stress have been studied more than once from acute stress, and showing alteration at the level of neuronal circuits. And we know that now the brain of a vulnerable subject exposed to an acute stress can undergo neurobiological changes that resemble more the ones due to chronic stress. And their recovery is only partial, and this can predispose them to develop behavioral symptoms. But neurons are not the only player in this game, since the maintenance of brain homeostasis is up to glial cells. And glial cells are a population of non-neuronal cells that have different shape and origin and exert a plethora of different functions in our nervous systems. And the changes of them can, restore the lost homeostasis. So the reactivity of glial cells is very diverse and complex and depends on the stimulus that triggers it. So, and their involvement in the stress resilience and vulnerability, acute stress resilience and vulnerability, hasn't been studied a lot yet. So to dig into this, we developed a model to discriminate resilience in vulnerable subjects. So we exposed rats to a single footshock stress and measured their anhedonic-like behavior afterwards by sucrose preference test. And by comparing the rat intake after stress to their habitual pre-stress consumption, we identify the group that was most affected by the acute stress as the vulnerable group. And as you can see, if it shows that, as you can see, the 2 days after stress, the rats vulnerable group consistently, drink less sweet solution compared to the other group. So we also saw that acute footshock stress can induce atrophy of the apical dendrites of pyramidal neurons in the prefrontal cortex of stress rats, irrespective of phenotype. So we deepened on this, and we measured at 2 time points, 24 hours and 48 hours after stress, the level of their neurotrophin, BDNF, and we saw that the vulnerable group have a significantly lower neurotrophin expression, and actually the resilience rats had it higher level of this neurotrophin, and also a higher level of dendritic marker MAP2, showing a positive response to the acute stress. 48 hours after stress instead, we saw a significant reduction of the dendritic marker MAP2 and the neuronal postsynaptic density 95 in the vulnerable groups, and without having neuronal loss at any time point. So we looked at glial cells, as anticipated, at the 2 time points, specifically microglia and astrocytes, and we looked at the density of astrocytes in the prefrontal cortex without detecting any difference among groups. But we saw an activation of astrocytes as induced by stress as early as 24 hours after stress that became reactivity in 48 hours after stress, with a higher expression of S100B selectively in vulnerable rats. And this is a neurotrophin expressed by astrocytes that usually is increased upon brain injury, so it's a measure of astrocytes reactivity. When we looked at microglial cell density, we saw stress-induced, higher cell density in 48 hours after stress, possibly suggesting a recruitment of microglial cells into the area. And actually, microglial cells were reactive as early as 24 hours after stress, and only in the vulnerable group. So we checked for signs of neuroinflammation, especially related to this pathway that is active in reactive microglia, and that involves the toll-like receptor 4 and the activation of the NF-κB pathway that could lead to a pro-inflammatory environment. So again, by comparing the 2 time points, we saw that a higher expression of the toll-like receptor 4 selectively in vulnerable rats, a stress-induced activation of the NF-κB, the expression of the active form of the NF-κB proteins, and a higher expression of cytokines exclusively in vulnerable rats. Actually, resilience rats show a higher expression of the transforming growth factor beta, which is a factor that has anti-inflammatory properties and then can dampen microglial reactivity. So this might explain why, as you recall from the slide before, I show you a stress-induced possible recruitment of microglial cells into the area, but then we found reactive microglia only in vulnerable group, possibly because the resilience rats express this transforming growth factor beta. So when we challenged rats 24 hours after stress with ketamine, a single injection of ketamine, and then we measured, molecular alteration 24 hours after this challenge, in the vulnerable groups, we saw a downregulation of the expression and lower expression of the markers that show reactivity of astrocytes and microglia, lower microglial cell density into the area, always prefrontal cortex, and a lower expression of the active form of the NF-κB signaling, and a lower expression of cytokines. So this probably had a positive effect on neurons, since we had higher, but it doesn't go, okay, a higher expression of the dendritic marker MAP2 in the ketamine-injected group compared to the vehicle-injected rats. And actually, we saw that ketamine injected after stress could reverse, could actually prevent the retraction of apical dendrites of the pyramidal neurons in the prefrontal cortex. So, in conclusion, we can say that glial cells, astrocytes and microglia promptly react to stress. We saw an upregulation, a stress-induced upregulation, activation of the NF-κB signaling, but this results in different outcomes in the resilience and vulnerable groups, since only in the vulnerable group we saw a pro-inflammatory environment. So we speculate that this could be due to the higher expression of S100 beta, S100B expressed by astrocytes that could possibly trigger the signaling through the toll-like receptor 4 in microglial cells, activating the NF-κB signaling and promoting the pro-inflammatory environment. Actually, in resilient rats, the activation of the NF-κB signaling could be responsible for the higher expression of the BDNF and the transforming growth factor beta, which are under its control. So glial reactivity and neuroinflammation in general could be responsible for the dendritic atrophy that we saw in the prefrontal cortex of stressed rats. Also because the microglia activity of synaptic remodeling can be triggered by a pro-inflammatory environment. So these data add a little piece of evidence that support the use of ketamine in the short term in vulnerable individuals, and could open new studies that can look at glial cells as target for therapy or for the development of biomarkers that could discriminate resilience and vulnerable individuals to stress. And this study was made possible through this collaboration, especially with the University of Milan and Genoa. And I thank you all for your attention.
Another beautiful presentation. Marta, thank you.
Thank you so much.
Fantastic slides, and you've clearly put a lot of effort into this. There's lots of data in that presentation. Marta's paper is now open for questions, if anyone would like to find their way to a microphone. Can I just ask, just to start, so what was the distinction in that initial test between a resilient rat and a vulnerable rat? How do you phenotype them in that way?
But we phenotype them just with the sucrosync test with the anhedonic-like behavior, and also because it's a rather easy, test to do in rats, and anhedonia is a core symptom of depression. So we didn't, do other tests to assess their depressive-like behavior in other ways. Also because this involves other tests that are stressful, and we wanted them to be stressed just acutely by the footshock stress.
Okay. And do you think if you bred vulnerable rats, do you think you could develop a substrain of rat that would be chronically vulnerable to these kinds of stresses?
Yeah, I think it's possible. There are also the Flinders-sensitive rats that that are bred and develop depressive-like behavior. So I'm sure it's possible to do that. We haven't gone in that way yet.
Okay.
No.
Okay, thanks. Good question.
Okay, that was a great presentation again, so really nice.
Oh, thank you.
So we've done quite a lot of work on acute stress. It's a very nice presentation, nice organization. Did you give the ketamine? When did you give the ketamine? I missed that. Was it after
24 hours after?
After, okay, great.
After stress, yes.
Yeah.
To have a translationally relevant treatment that, thinking about a person that is exposed to, some traumatic event, and then if we are able to understand who needs the treatment because has a risk for being vulnerable, then you inject ketamine.
Okay.
This is the thinking, the rationale of the...
Just for the future experiments, because we've also found that while you can change the dendritic arborization down in the prefrontal cortex, the amygdala is opposite. So have you got the amygdala, and will you look at that?
We have the amygdala, we have the hippocampus,
right.
So we want to go in that direction, of course. Yes,
great.
yes, yeah.
Great.
Okay. One last question, very quick one. Why did you choose ketamine?
Why?
Why did you choose ketamine for this particular experiment?
Oh, because it's a, it's a rapid-acting antidepressant, So, and actually, it has been proposed to be a treatment for PTSD, and this is a model that tried to mimic PTSD. So this is why we wanted to try ketamine.
And was it
Subanesthetic doses, of course, of course, yeah.
Okay. Perfect. I think we'll move on. So thank you, Marta. Great presentation. Our next paper is entitled Defining the Role of NAV 1.8 in phytocannabinoid-induced analgesia, and it will be given by Avi Priel from the Hebrew University of Jerusalem. Avi.
Thank you very much. Thank you very much for coming this morning. So, as you probably know, medical cannabis is mainly prescribed to treat chronic pain. Here you can see an example from 2 months ago. In Israel, 54% of prescribed medical cannabis or licenses that the Israeli Ministry of Health gave were for chronic pain, when the other prescription was only 17%. And this picture is throughout all the world. The main indication of cannabis is for treating chronic pain. And this was now that it's already, in most countries already in some form legalized. And it was also before it was legalized, it was already prescribed, quote unquote, for chronic pain, especially in cases of palliative treatment. So the question that we still have is how medical cannabis change the pain pathway and achieve its analgesic properties. And we mainly focus on the two most abundant cannabinoids, THC and CBD. And a striking phenomena of both of them is that both of them have similar potency as analgesics. Although as THC is the psychoactive compound, while CBD is the non-psychoactive compound when we talk about the major compounds in cannabis. But both of them have analgesic properties very similar, and if we don't take the psychoactive in account. And what more interesting in that is that at least for CBD, you have a very low affinity to CB1 and CB2, and we cannot actually talk about CBD acts through CB1 and CB2. So we try to figure out what and if CBD and THC have any target in the periphery that is in the pain system, in nociceptors, and if they can actually act on the neurons directly. In order to achieve that, we first isolated the neurons from a trigeminal ganglion and recorded the evoked action potentials. And here you can see an example for that. We focused on the TTX-resistant neurons because they are an excellent marker for nociceptors, the neurons that are responsible for detection and noxious stimuli. And as you can see, CBD, sorry for that, I don't know from where it comes. CBD blocks most of the evoked action potential or evoked firing, while THC has a different inhibition, but both of them inhibit directly the activity of the neurons. And if we look in dose-dependent manner, we can see that in 10 micromolar CBD already abolish or diminish dramatically the amount of firing, while THC also cause inhibition, but to much less extent. So the robust inhibition of CBD led us to check whether this is done through sodium currents that initiate the action potentials. So what we did, we isolated the sodium currents And this time we look on both TTX-resistant neurons and TTX-sensitive neurons. And we look on the different activity to CBD. So as you can see, again, we see a dramatic inhibition in the TTX-resistant current. However, in the TTX-sensitive, we have much less inhibition. When we look on the TTX-resistant throughout all the doses, and you can see here CBD in red and THC in blue, you can see that CBD have similar dose response for the sodium currents as he had for the firing, and also THC have similar dose response that we saw on the TTX resistant. And if we look on the TTX sensitive, we see a totally different picture. Now CBD is also more potent than, or more efficient than THC. However, both of them have a very low potency and almost don't inhibit the current. So we know now that, or at least this is what we found, that the TTX-resistant sodium currents are sensitive to CBD in the same manner that the TTX-resistant neurons firing. And that led us to move to a heterogeneous system and to focus on the main TTX-resistant channel NaV1.8, and also we looked on the main TTX-sensitive channel, which is expressing nociceptors, NaV1.7. And we expressed the NaV1.8 in ND723 cells and the NaV1.7 in HEC cells. And we did the same experiment that we did for the nociceptors regarding the sodium current. And again, you can see that NaV1.8 is dramatically blocked by 3 micromolar of CBD. And also the NaV1.7 current is blocked, but to much lesser extent. If we look on the dose response, we see a very similar picture to what we saw in the neurons regarding the NaV1.8. We have now a potent and efficient block of CBD. However, THC is much less potent, however, is more efficient in the isolated channels. If we look on other two common in the plant cannabinoids, CBC and CBG, we see a very interesting phenomena that CBG act similar to CBD, while CBC act very similar to THC. Okay, CBG is actually have the same potency and efficacy as CBD, and CBC have very similar dose response as THC. When we move to the NaV1.7, we see a totally different picture, and this picture is also different from the neurons, the TTX-sensitive neurons. First, we see a full block of the currents in higher concentration, much higher concentration than what we see for CBD in NaV1.8. However, we still see a complete abolition of the current. And we see that all the different cannabinoids have very similar dose response, which means that what we think is that the NaV1.8 have, in its binding site, have the ability to differentiate between the different cannabinoids due to their structure. We can talk about it later if you want. While NaV1.7 is much more promiscuous, it can bind all the cannabinoids, however, in much less potency or efficacy, and efficacy is the same. So we have now a clear target, which is NaV1.8, and the reason that this can be a target is that if we look on the dose response and we look on what people found regarding the pharmacokinetics of CBD and THC, so if you push the results a little bit, you can get up to 1 micromolar of CBD, something like half an hour after a patient use higher dose of CBD or rich CBD plants. And this fits inhibition while in NAV 1.7, in 1 micromolar, we have a very small inhibition. So now we wanted to look whether CBD acts on NAV 1.8, similar to many other antagonists of sodium channels, which mean whether they have a use-dependent mechanism. So what we did the classical use-dependent experiment. We gave a train of stimulation in different rates. And you can see here, this is the control when we don't apply anything besides saline, and we don't have, of course, any inhibition. However, when we apply CBD, you can see that there is a use-dependent inhibition. And also, as a control, we took the local anesthetic bubovacaine, which, of course, is the classical use-dependent molecule. And we see that we have a use-dependent in 5 Hz and a stronger one in 10 Hz, which is fit very well with a drug that acts in a use-dependent manner. And here you can see the statistics of the different results. So actually, NAV 1.8, CBD at least, act on NAV 1.8 in a use-dependent manner. And this is also the case for NAV 1.7. Also in NAV 1.7, we see a use-dependent inhibition, however much smaller than the one that we see for NAV 1.8. However, it's still a use-dependent mechanism. So now that we see that the resemblance between the CBD and the bubovacaine, at least in the mechanism of inhibition, we ask whether they also share the same binding site, because we know the binding site of the local anesthetic. So what we did, we introduced a very common mutant, phenylalanine to alanine. In this case, in the human NAV 1.8, it's in position 1759. However, in all the different sodium channels, this position regarding to the numbering has a critical role in the binding of the local anesthetic. And you can see here that this mutation, bubovacaine, 30 micromolar of bubovacaine, almost don't inhibit the channel anymore. And this is also the case that we see for CBD in 3 micromolar. We see that this mutation almost eliminate the inhibition of CBD. And if we look on the dose response of the two, we see this is the bubovacaine, this is the mutation, the gray. We see the rightward shift, which is so common to this mutation throughout all the literature. And we see the same exactly behavior for the CBD, a rightward shift of the sensitivity to the antagonist. So, to summarize, CBD and THC block nociceptor firing by inhibiting sodium currents. CBD is more potent inhibitor than THC of both firing and sodium currents. The nociceptor's NAV channel, NAV 1.8, is potently inhibited by CBD. CBD and CBG are potent inhibitors of NAV 1.8 compared to THC and CBC. And the last point, CBD inhibits NAV 1.8 through the local anesthetic binding site. So last, and obviously not least, to the members of my lab, and specifically to Yossi Maatuf, that all the results that you saw was actually done by him. I'm just doing the talking, he's doing the work. And to my collaborator, Alex Binstock, and of course, for the funding agency for their support in our research. And obviously, thank you for your time.
Thanks, Avi. Another very nice presentation, great slides, and from an institution, obviously, with a long history in cannabinoid research.
Yeah.
Questions from the floor, anyone? Can I just start? Obviously, CBD is now approved for the treatment of epilepsy,
right,
or specific subtypes of epilepsy.
Right.
Do you think that one of the mechanisms by which it has an anti-seizure action might be through an inhibition of sodium channels?
it's speculation.
Yeah.
To speculate, I'm always willing to do. That's not a problem. I would like to believe so. Okay, that because I think also in the pain system we don't talk about because it doesn't get to this concentration like we did in the in vitro or ex vivo, whatever you want to call them. You don't get to that. We just change the rate of firing, which this is exactly what we see for all the other anti-epileptic drugs that works on sodium channels.
Yeah.
That you just change the rate of firing. You don't inhibit, of course. You don't want to inhibit also.
Sure.
So I think that it may be a mechanism, but I didn't check that.
Okay, it's fine to speculate.
Yeah.
Question over here.
Thank you, beautiful talk. So I am interested in drug combination therapy. There are two drugs, A and B. Imagine that drug A is morphine, but we want to add a second drug, B, no? That cooperativity works with morphine in order to lower the concentration, the dose of morphine. No? Imagine that for this drug B, we can use a cannabinoid drug. So what drug would you use, THC, CBD, or it could make sense an inverse agonist of CB1 in the case that you want to, maybe in nitrodemergic receptor between MOR and CB1, maybe an inverse agonist could do something unexpected?
So it's totally different approaches. So if you talk about the THC approach, I'm divided into THC and CBD approach, okay? So if you combine it THC with morphine, you're talking only about CNS now, okay? Effects. So if we look on CNS effect, inverse agonist can work. I don't see a reason why, if you think that the main mechanism of THC is through CB1. If you talk about the CBD approach, then what we talk about is actually what I think we talk about, okay? Again, speculation. We talk about the CBD that acts in the periphery while the morphine acts in the central. And that combination, I think, can actually be successful. The inverse agonist is a very good question. I really need to think about the inverse agonist for CB1. THC, THC and morphine, at least he would be happy. But that's my...
Thank you.
Okay?
Thank you.
Okay.
Thank you.
Thanks, Avi. I think we'll move on. Thank you. The final paper of this morning's session is entitled Autism Spectrum Disorders, Sex Matters in a Mouse Model of Idiopathic Autism, and will be given by Luigia Trabace from the University of Foggia.
Thank you very much. Thank you for the introduction. Today, I'm going to talk about how sex matters in an idiopathic mouse model of autism. Autism is a complex disease with symptoms. It's characterized by symptoms that include, for example, repetitive behaviors and restricted interest, or is characterized by impairments in language and communication and deficit in social interactions. And this complex disease affects 3 times more frequently male than females. And studies suggest that this low incidence that we can see might be actually underestimated. And this because we use clinical measures to measure behavioral symptoms that are mostly studied in males instead of females. And indeed, our current diagnostic tools or measures that we use, indeed at the moment are considered quite rather ineffective. In fact, as you probably know, and as a lot of published papers confirm, today's sex differences in ASD might be partially due to our current ability to capture repetitive and restricted behaviors, then mainly are present in males, whereas missing those expressed in females. And this also because today the majority of studies are currently performed in male animal models. So our aim was to understand if there are sex-related differences in ASD-like behaviors, at least in our mouse model and in our hands. To do so, we used the BTBR mouse models. That is an inbred mouse strain that typically shows a behavioral phenotype that in some way resembles the symptoms, or at least several symptoms of ASD. A few years ago, we have already characterized and from a behavioral point of view this mouse strain, and as you can see, we found an overall decreased social exploration, either in time spent or in the frequency in BTBR males, as well as a decrease in overall adding. Also, we found an increase in overall alone inactivity, such as an increase in passive receiving social contents and overall grooming. And this work was done in male. So when we tried to compare male and females, we found that, as you can see, in marble bearing test, we found a profound difference between male and females, as well as in grooming behavior. And these tests mainly measure the repetitive behavior of animals. When we try to compare male and females in other behavioral tests, such as Holborn task or open field test, we could not reveal any difference between the two sexes. And these tests are mainly used to study or to reveal emotionality of animals. So we confirm that, for example, both sexes shows hyperlocomotion, at least in our hands and at least in this test. When we try to understand the social interactions of these animals, we found that male and females did not show any differences in social frequency, but as you can see, the BTBR mice shows decreased social interactions as expected. But we found a difference in the two sexes when we evaluated the non-social behavior in terms of duration or the frequency. So as a first conclusion of this talk, we can confirm that BTBR females display different patterns of repetitive behaviors compared to males. And male and females showed both hyperlocomotion, as I said, and also female and males reported social interaction deficits, while females alone showed a decrease in exploration of non-socially related objects. I'm showing you now just, please consider very preliminary data. We try to understand how we can ameliorate these symptoms, or at least we can prevent. And published paper suggests us that in ASD, it is important an oxidative process. So we tried to explore the activity of beta-carotene, that is an antioxidant molecule, but also beta-carotene is also a potent inducers of CD38, that is oxytocin ectoenzyme regulator. Why this? Because it has been shown that in ASD patients, we found a lower plasma of oxytocin together with also oxidative stress. So we tried to at least to improve the behavioral impairment that we have seen in BTBR mice. To do so, we treated our DAMs with beta-carotene twice a week during the pregnancy, and the experiments were done in the offspring at 10 weeks of age. And we found that beta-carotene treatment was able to decrease marble barring and grooming duration in male BTBR offspring, as you can see here. Also, we found that beta-carotene was able to reduce nose poking in the all-board task in male and females offspring. And in the social interaction test, we found that beta-carotene treatment was able to improve the frequency of social interactions, both in male and in female offspring. So our take-home message is that BTBR mice certainly display a sex-specific behavior, at least in some experimental tests. And there is, of course, an unmet medical need to understand and to evaluate how this behavior manifests in females compared to males that are more studied. And beta-carotene administration during pregnancy, so from a prenatal point of view, might represent a useful approach to prevent or to ameliorate in some way the ASD behavioral dysfunction that we have seen. So I'll thank you all for the attention.
Thanks, Luigia, for a great presentation. We'll open the floor for questions. Again, please use the microphone. Go over here first.
Good morning. Wonderful talk. Thank you.
Oh,
this
sorry.
is a very naive question because this is not my area. But from what you're saying, we need a reassessment of autism spectrum disorder assessment.
Yes, I think definitely, because at the moment we think that the higher prevalence that we see in males is just an overestimation, or on the other side, the lower incidence that we see in females is just an underestimation, because we use different diagnostic measures. For example, in females, autistic females, they do more masking or they do camouflaging. So they got the diagnosis of autism later in life, even if not misdiagnosis. So we need to reassess from the diagnostic point of view, from the beginning, the story. And so on, the treatment should be adjusted to the sex, because the symptoms could be so different.
Thank you.
Thank you.
Thank you. I'm not an expert in autism, but I'm an old pharmacologist who've always insisted on looking at both males and females. And one of the key things which you might want to try is that we had actually a program on male sexual dysfunction, but looking at 5-HT1A agonists gives you quite remarkable differences between males and females in behavior. It's the biggest effect that I know in terms of differentiation between sexual activity, between some aspects on mood, and that means the rapid firing is critical, and that's a rather big controller of behavior. So it'd be quite interesting and very quick for you to look at some selective 5-HT1As. So good luck with it. It's a lovely presentation.
Thank you for your suggestion. I think that 5-HT1A receptors are critically involved in this. So our next step will follow your suggestion. Thank you.
Question over there.
Hi, great talk. So there's a male bias in the literature by male researchers which seems to have spilled over into diagnoses, but there also is a male bias in the design of the tests clinically and preclinically. what changes would you make to some of the preclinical tests that we use in mice to look at autism?
Great question, and also a big challenge. Yeah, definitely, you're right. We have to address also the test, to perform the test based on the sex bias. Yeah, we have to think deep on this question. I have not answered right now. Thank you.
Thank you.
Okay. One last question. How did you decide on the twice-weekly administration schedule for beta-carotene?
Sorry?
Why you gave beta-carotene twice per week?
Yeah.
How did you decide on the?
Oh, we decided just on previous published papers, just to follow a protocol that it has been already proved.
Okay.
Just to have plasma levels detectable. And it's just on previous data.
Okay, thank you. I think that's it. So, Luigia, thank you very much.
Thank you.
I wish the weather was like this in Glasgow, but it's not, unfortunately. Thank you, everyone, for a fantastic session this morning. It's a real shame that we had some high-quality presentations. It's a shame that we had this early in the morning on the final day. Great talks from everyone. Beautiful slides, I have to say. Everyone had really impressive slides. Thank you all to the speakers, and also thank you to the audience members and your participation this morning. And with that, we'll close the session.